Welcome, everybody. Rush University Medical Center, Division of Nephrology Renal Biopsy Conference for March 21st, 2024. We were off last week. I want to wish everybody a belated 1-week-old World Kidney Day, and I also want to wish everybody a happy Ramadan. We're going to try to be a little more regular with our schedule. It's easier said than done. We're also continuing to work on the CME. We're not sure where that's going. It's been a lot more difficult than in the past, and we may have to abandon it, but Dr. Bexley is working on that. I would remind people, that CME and MOC is still important, but if you're not aware and you're up to date, you can register with an up to date for CME, and then actually it'll automatically, as long as you sign in your ABIM number, it will also transfer to MOC credit. So if that is an issue, that you need CME or MOC hours, you can easily get it through up to date. I visit it all the time, just looking up stuff, confirming stuff, looking for references, and hopefully you've got access to that. So that's one very easy way to get CME and MOC. So if we do drop it, I think we'll be okay. But we're still working on it. It's been very, very frustrating, and Dr. Baxi has about ready. I've told him it's maybe time to give up, but regardless, here's our privacy statement. Everything's preserved. Patient identity has been protected, and we have nothing to disclose as usual. We've got a good case. Bhavna, our first-year fellow, is going to read us the case. Bhavna, you want to take over? You're muted.
Go ahead, Bhavna.
Okay, I wasn't able to unmute myself before. Okay, so we have a 70-year-old Hispanic woman with a past medical history of stage 4 myoepithelial carcinoma of the left submandibular gland with metastasis to multiple places, including the left humerus, lung, liver, ribs, and left kidney. She's had resection of the left submandibular gland and underwent radiation therapy as well as chemotherapy, and also has a history of type 2 diabetes. She comes in admitted from clinic with complaints of fever of 102, chills, and generalized weakness. She has had a new erythematous rash of the left lower extremity associated with lower extremity edema. The rash is tender and non-pruritic. She was diagnosed with RSV approximately 10 days ago and treated supportively, and cough had improved. Admission creatinine was 1.9 and it was 1.0 2 months earlier. In regards to her oncologic history, she's had left submandibular gland adenoma with resection back in 2011 and recurrence in 2017, which was then resected. In 2018, she had a biopsy of her left humerus lesion consistent with metastatic myoepithelial carcinoma, received radiation therapy. She was also found to have a left renal lesion consistent with metastatic myoepithelial carcinoma, status post-radiofrequency ablation. She underwent trial treatment, which is MD/M2 inhibitor, APG-115, but was discontinued due to myelosuppression. She continued intermittent radiation therapy to the left humerus. She was on ipilimumab and nivolumab, both checkpoint inhibitors, for 14 months, ending treatment 1 year prior to current presentation. She was also on axitinib, which is a tyrosine kinase inhibitor, and thereafter, was on this until 1 month prior to presentation. She underwent cryotherapy for a left upper lobe endobronchial lesion. On day 4 of admission, her creatinine had increased to 2.4 and nephrology was consulted. Her review systems was positive for decreased urine output, urinary frequency, and constipation. She denied any palpitations, dyspnea, abdominal pain, or nausea, vomiting, dysuria, or hematuria. Past medical history and surgical history is as above. She has a history of hypothyroidism as well as type 2 diabetes. The medication she was on was levothyroxine, gabapentin, and recently started on benzonatate for her cough, and albuterol inhaler, PRN, as well as Robitussin. No known drug allergies. In regards to her social history, no alcohol, tobacco, or recreational drug use. Family history is remarkable for diabetes, unknown cancer, and thyroid disease. On exam, she was febrile at 100.6, blood pressure was 140/60, pulse was 90, respirations were 16. She weighed 182.2 pounds, BMI was 31. And on exam, pretty unremarkable except for a few wheezes on lung exam. She had 1+ lower extremity edema and left lower extremity diffuse erythematous macular rash that was tender to palpation. Her lab work was significant for sodium was 136, potassium 4.7, chloride 100, bicarb 22, BUN 27, creatinine 2.4, adjusted calcium of 9.6, ALT 8, AST 16, albumin of 3.1. Her CBC had a WBC count of 8.3, RBC count of 2.94, hemoglobin of 8.8, MCV of 95.1, and platelets of 80. Her UA was positive for 100 milligrams per deciliter of protein, 3+ blood, 182 greater than 182 RBCs, positive leukocyte esterase with 15 WBCs, and moderate bacteria and 150 squamous epithelial cells. A UPC showed 4.1 grams, as well as a UAC of 1.9 grams. Serologic workup showed C3 was 120, C4 34, and Hep B and C were negative, as well as HIV. Anti-RNP/SM, SSA, SSB, anti-double-stranded DNA, ANA, and ANCO were all negative. PLA2R also was negative. SPEP showed no monoclonal protein and UPEP with no paraprotein detected. She had a retroperitoneal ultrasound which showed an exophytic solid isoechoic right lower lobe renal lesion measured about 6.0 by 4.4 by 5.1 centimeters. The left kidney was evaluation was limited due to body habitus, but measured 10.6 centimeters in length. The urinary bladder was unremarkable. The creatinine kept climbing, and at 4.5, a renal biopsy was performed.
And here you can see leave the graph up. So here you can see admission where she came in a couple days later. We were consulted, and several days later we had the renal biopsy performed. I might add we have a visitor. We're glad to see Dr. Juan Carlos Velez. Now, if he would have presented this case, the next 4 slides would be the most beautiful urinalyses pictures in the world. We don't have that, but if you don't follow him on Twitter, you really should. He has routinely posts incredible, beautiful urinalysis microscopy slides. He's become quite the expert in it, and you can learn a lot. So I'm preempting it so he doesn't ask me if we looked for red cell casts. So I'm bribing him by flattering him so he doesn't embarrass me and tell us exactly what it looked like. But she had obviously a lot of hematuria here. It's not irrelevant, I suppose, because she has a renal mass and there's hematuria. So it would be nice to know what exactly this looked like. But with that, I'm going to move on here, and we're going to go to a poll. Oh, does anybody have any questions? I'm sorry.
Bill was asking, was the patient oliguric?
She was not when we had first been consulted.
Do we have an LDH? Do we have a lactic dehydrogenase?
We might. I'll have Bhavna can maybe pull that up while we're going to the first poll. You know, the days of that being part of the CMP are unfortunately long gone. And I've often argued that as terrible a test that is, it's often a very useful test and it costs them nothing to add, but it's been replaced because of its non-specificity, but I think it's still a great test. I wish it were still on the CMP. So this is poll number 1. What do you think this patient has? An immune checkpoint inhibitor related lesion, diabetic nephropathy, ATN, or TMA from the tyrosine kinase inhibitor, or something else, and you can put your diagnosis in the chat.
I have an LDH of 394.
Thank you.
Thank you.
And did you have free light change, Bhavna, while you're there?
The kappa lambda ratio was 1.46, lambda chains were 12.68, and kappa was 18.46.
Thank you. Boy, you're fast. I'm glad you're on the computer and not me. So the answer is, yeah, we did have them, and the light chain ratio
Hap
was normal as well.
Do you have a haptoglobin, Bhavna, while you're on a roll?
277.
Look at that. Okay. So, waiting for, come on, a few more people to vote
So
to get
Dr.
the-
Glassick put number 5 other TMA, but number 4 is in the number 4 TMA is there.
I'm assuming he's TMA
Got
not
it.
related to
Got
tyrosine
it.
kinase. Oh,
I
okay.
put the wrong
Hmm.
I put the wrong thing in.
Okay, yeah, no
That's
problem.
my other.
All right.
I see. Okay.
All right. So I'll end it there.
Yeah, I mean, it's an interesting question and it's kind of limited. We're kind of talking about, general pathology, but also mixing up diseases and whatever else. Dr. Glassick says crescentic GN is not exclusive to, number 1, for instance. But yeah, good point. So we'll show the results here. We've got 41%, say, immune checkpoint inhibitor related lesion. And, that could be, I think our discussant can say what that would mean. And relative to the timing of that. We always put diabetic nephropathy in there because what's common is common, but we've got ATN, very small, but it really is between a TMA from possibly the tyrosine kinase inhibitor or an immune checkpoint inhibitor, and we've got a couple others here. So I'm going to ask Dr. Whittier to open up the discussion. If you could leave the poll up so he can kind of approach each of these, what he thinks about them. Bill,
Yeah, sure.
you on?
Yeah, thank you. Yeah, I am here. And I would say that, in all these cases where you have a significant malignancy versus the therapy, it almost reminds me of back in the days of HIV, where is it the HIV causing the disease or is it the therapy causing the disease? And we're always trying to figure that out. In our situation here, we have somebody who's got significant AKI, who's got a significant metastatic cancer and has been on a lot of therapies. So it's always hard to sort of sort those two things out. And then there's also other things that could happen too, just independent of their clinical presentation. And so, renal related oncologic issues, I think in this situation, I think could she have an underlying membranous causing some proteinuria at baseline, and then there's AKI from something else? I think that's possible, but more likely, I think that in this case, because the significant AKI is there, may be related to some of her therapy as opposed to her underlying malignancy. And we could be wrong. And so, because her underlying therapy is actually could be quite nephrotoxic. We have checkpoint inhibitors to start off with, and those classically cause interstitial nephritis. She has a rash, which would go along with that, but then we're told later that the rash may be cellulitis. The checkpoint inhibitor timing of interstitial nephritis is very different than our classic sulfur-related interstitial nephritis or our penicillin-related, and it can be immediate, but it could also be quite delayed up until months and months later. So it doesn't really fit. It doesn't necessarily have to be you just get the Keytruda and then day 2 you get the interstitial nephritis, and so that might fit in quite well here to interstitial nephritis. But interstitial nephritis is usually more of a slowly progressive creatinine over time, as opposed to such an acute creatinine developing over time. And that's sort of why I was asking about the presence of oliguria, because while oliguria doesn't really have that much diagnostic specificity, we do think about oliguria with rapidly rising creatinine in the setting of either ATN or possibly even TMA. And so even though she may have underlying proteinuria from diabetic nephropathy in number 2, I think 3 and 4 are a little bit more likely just because of her rapidly rising creatinine. Could she have thrombotic microangiopathy? Well, yeah, I mean, the TK inhibitors are certainly associated with that, and the timing would fit that as well. Do you have to have a low haptoglobin and an elevated hemolytic anemia? No, absolutely not. Do you need to have the microangiopathic hemolytic anemia process to have a TMA from tyrosine kinase inhibitors? No. And so I think that if we see a TMA here, it'll be hard not to blame her TKI. And there was a lot of initial. So if we see a thrombotic microangiopathy here, it'll be hard to not blame her tyrosine kinase inhibitor. So I'm kind of going towards, because of the rapidity of the renal failure, towards number 4, TMA. There may also be some ATN there. And I think her background proteinuria may be due to diabetic nephropathy. Lastly, I'm not quite convinced that she really has an active urine. She has a lot of squamous epithelial cells. Clearly, she has hematuria there in the urinalysis, but I'm not quite sure if it was really that great of a clean catch. And if she did have hematuria, you could still see that with, 1 or 4. With a TMA, you can still have a certain percentage that have hematuria. So I put my number 1 diagnosis as number 4, TMA, and I think that that's what we'll see in the biopsy.
Great. I want to point out Dr. Reen added another diagnosis of malignancy-related crescentic GN. That's, when you look up cancer-related glomerular disease, that's there's a long list of cancers that's associated with that are often, often ANCA negative. So I think that's a very good point.
And
Mario,
even
Dr.
the immune checkpoint inhibitors themselves are not just limited to interstitial nephritis. We obviously have a whole host of glomerular disease, the most common being a post-immune necrotizing GN, even from the checkpoint inhibitors. So the differential here is pretty tough. But I think Dr. Rubin's got his hand up. Sorry about I may have jumped in line in front of you there, Mario.
No, it's fine. I was wondering if you could please comment on the discrepancy between the UPCR and the UACR and how that helps.
I was also, that's another reason I was asking about oliguria, although I didn't mention it, so I'm glad you brought that up. I think the UAC of 1920 means there's a glomerular process there. You can't have 1920 milligrams of albuminuria without having some glomerular disease. So I was wondering if there was an underlying baseline diabetic kidney disease, is kind of how I was putting that together. Classically, in our glomerular diseases, you're going to have 2/3 albumin to creatinine, albumin to protein creatinine ratio. Not for all of them, but especially for diabetic nephropathy. So this is a little less than that. This is about half. It's not 2/3. But again, she's in acute kidney injury. I'm not quite sure how reliable a PC and AC ratio are in that setting, but I know they're less compared to someone who's in steady state.
What they're not is it's not 20% and it's not 90%, which would really point you towards 2 very specific different kind of processes. Bill,
I think,
go ahead, Dick.
I think Bill's raised a good point here. In a patient whose urinary creatinine excretion rate is diminished, it is not useful to measure UPCR as an indicator. Now here, of course, we're looking at a ratio of 2 proteins, one a general protein and one a specific protein. So perhaps the creatinine element doesn't enter into the equation because it'll be the same in both. But the point I would like to make is that although AKI really rolls off the tongue very easily, in a case like this, I would have called this rapidly progressive glomerulonephritis, not AKI. And here, of course, Dr. Velez could be very helpful, because if 20% of those red cells in the urine are acanthocytes, please forget about acute tubular necrosis and interstitial nephritis. This is a glomerulonephritis. It's sad that we don't take the time to look for acanthocytes in the urine sediment. It's so easy and so useful. And Dr. Velez has shown beautiful instances where it makes a huge difference in the direction of your diagnostic analysis. And I really think that although the point is she's got white blood cells and squamous epithelial cells, but why not look for acanthocytes if you can see epithelial cells? Makes no sense.
Yes, agree. We have no defense on that. Very good point. I tried to nip that in the bud, but of course, you had to call us out even further. Good point. Bill, I want to ask you something. This checkpoint inhibitor was 14 months ago.
That's on the later end of it. I think I think it was, God, the last time I looked at the study, I thought that wait, no. You know what? I can't remember. I'm sorry, but I think it was around 3 to 4 months was the highest incidence of interstitial nephritis after getting a checkpoint inhibitor. I'm risking not quite knowing that, but 14 months is a little bit outside of the window, but I thought that it was somewhere between 1 to 9 months was the reference range.
Seems
I'll
long to
look up
me.
that
Dia,
paper.
Dr. Wagesbach, could you unmute yourself and tell me what your thoughts about this case are?
Yes, I think Bill already did a wonderful job of going through the differential and the comments that we had. I do think that, you know, on my differential, the TMA is the highest, but I do think that, you know, as Dick pointed out, the rise in the creatinine very quickly, and someone who, when I reviewed the case, because I missed the beginning, was not, you know, didn't have any underlying injury when they presented to the hospital. They came in for what looks like a procedure, if I'm correct. So I think that is you know, definitely something to be concerned about. The history of the underlying diabetes before, I think it'll be interesting to see what's in the biopsy, because there's probably some underlying CKD prior to whatever this event is that caused it. And then the only other kind of comment I had along the lines of the urine, I agree. We have a nice little lab to spin it, and there's so much you can get from it. Sometimes the timing of when the urine's available is problematic. But then also just to remember for those on, although this patient didn't have gross hematuria, the red blood cells can contribute to the protein measurement in the urine too. You know, once you're over a certain amount. So just to always keep that in mind, if there was gross hematuria that you're measuring proteinuria, you're going to have an abnormal elevation from the blood. So.
Yeah, so yeah, that's all good. I want to Juan, JC, what do you think's going on before we read the biopsy without kicking us any further?
Yeah, well, thanks for the generous comments about microscopy. But you know, it's interesting because this is a scenario where it'll be particularly helpful because the suspicion here is thrombotic microangiopathy versus something different based on the exposure to the tyrosine kinase. So I agree with, you know, everything has been said already. But interestingly enough, thrombotic microangiopathy, even though it's a glomerulopathy that presents with damage in the glomerula, mesangiolisis, you see the duplication of the GBM and all the features that we know, the sediment is not particularly as impressive as a post-immune GN or a crescentic IgA or a proliferative glomerulonephritis typically are. So if I see numerous acanthocytes, my suspicion for thrombotic microangiopathy quickly goes down. So in this particular case, I just wanted to make that comment about the distinction that the urine sometimes can give us. But you know, I don't really have much to add to what has been discussed, other than the patient is diabetic. I wonder how long has been a diabetic. He's been proteinuria part of the proteinuria could be from that. So we may have some evidence of early diabetic nephropathy on the biopsy, but clearly it doesn't appear to be the reason why this patient is enough. So yeah, I think it's ANCA negative post-immune GN from cancer is certainly number 2 on the list for me after the TMA.
So
Roger?
yeah, I want to say one thing, Dick. You know,
there is a serology that seems to be missing here that probably would be worthwhile doing in a patient like this. It's anti-GBM disease. Anti-GBM disease has followed immune checkpoint inhibitors. I can't say it's ever been associated with myoepithelial malignancies. Uroepithelial, yes, it has been associated with it. And any patient with RPGN and a sediment showing both heavy proteinuria and hematuria, I think should, when they have an ANCA, also have an anti-GBM.
I think that's a really good point. If you're going to use the term RPGN, you should really, and I think there's no reason not to put, you know, depending what you make of the urinalysis, you can't deny AKI, hematuria, and proteinuria, And that really defines RPGN. And if you're going to talk about RPGN to the ANCA, you should add an anti-GBM. We often don't do that. It's such a rare disease, but that's no excuse either. That should be in the armamentarium of that. I think that we should take a look at the biopsy now. Oh, I just wanted to point out, this patient didn't really look that ill. She basically, had a fever, and they got it, and because of everything else, they brought her in, and her creatinine was a little elevated. Thought, well, she's just dry, and she'll get better. Fever got much better. They gave her, little antibiotics for her leg, and that felt better. And then her creatinine just kept climbing, and that's what really prompted the whole thing. And the story got complicated when the creatinine was climbing, despite her. Really, she wasn't really that ill. That doesn't mean that patients that aren't ill don't get ATN. But let's move to the biopsy here and spin the wheel. Dr. Coleman, first year fellow. I think this is a couple weeks in a row. You are the new chosen one.
New Steve.
The new Steve. Yeah, Steve thought the wheel had it out for him, but not true.
All right, try to unmute yourself. Where's Michael? Go ahead. Can you unmute yourself and see?
There we go. Yeah.
Okay, perfect. I'm going to share the screen and give you control. So even in this picture, it lands on Steve, which is interesting. Have to change that.
It's a real wheel. We're not cheating on that one.
Let me see here. Control. All right. Go ahead and click.
Okay.
All right. Remember, there's a lag. Oh, yeah, that's you.
Okay, perfect. Okay, so this is trichrome stain. We have 2 cortex here, and we're looking for fibrosis, looking at the areas that are light blue. I would say maybe like 20% of the cortex has fibrosis in it at a glance.
Yeah, kind of focal. Yeah, I agree, Michael. Not very significant.
Cool. Okay, and then this is an H&E stain. We have our glomerulus here. And then we have the tubules on the outside. So first, these do look like red blood cells. Are these red blood cell casts?
Yeah.
Okay. And then actually looking at the glomerulus, I don't see many open capillary loops. There are some, but it looks like there is some mesangial expansion here. And then maybe a little bit of hypercellularity too.
Yep.
Aside from that, is this a little bit of sloughing in the tubule, David?
We'll see on the PAS stain that the tubule's better. Yeah.
Okay. But yeah,
and then there's an arteriole right there at 6 o'clock that looks widely open.
Oh, this.
Yeah, right there. Yeah.
David, do you think that there is lobularity accentuation of that glomerulus, which may help with the diagnosis?
That's a good pickup. Mild lobularity. Yeah.
Okay, another H&E stain. This does not look quite the same as the last one. This is abnormal. I don't know, is this a crescent or is this just?
Yes, it is, okay. Michael. Yeah.
Okay.
So you're a crescent, and in fact, you can see right in the middle, there's a mitotic figure. You're right on it. Yeah.
Cool.
The parietal epithelium's revving up and proliferating.
Gotcha. And then the glomerulus is just kind of scrunched up because you have this crescent here.
Yeah.
And then you have all these red blood cell casts and the tubules again.
Yes, actively growing.
That's about all I see here.
Okay.
Okay, there's a PAS.
Call that a baby crescent, Roger.
Okay.
There's a PAS stain. This is a crescent. It looks like. Oh, sorry about that.
That's not a baby crescent.
No,
No, this
That one's a
big
mature.
boy.
that's an old one.
Matured. And this is the scrunched up glomeruli again. And yeah, I don't see too many other things in this slide. It looks like the tubules all look pretty okay to me.
Yeah, the one right below it, there's some loss of brush border.
Here.
Yes, some ATN. Yeah.
Okay. And then another kind of big boy crescent here, it looks like.
Yep.
And, glomerulus again kind of pushed together. We have our tubule surrounding. This actually does look like sloughing, right?
Yeah,
In the tubule?
tubular necrosis. Yeah.
Okay.
Yeah. And then it does look like the mesangiums are kind of mildly expanded by matrix in the glomerulus throughout. Yep.
Okay.
Yeah.
Okay, so this is silver stain, and then this is not normal. This looks like there's breakage in the capillaries here.
Yeah. Yep.
Okay.
Ruptures, breaks.
And then is this the crescent on the outside?
No. You're outside the glomerulus there in the interstitium.
Got it.
The go back inside Bowman's capsule. Yeah. The crescent is just starting to form. Yeah.
Okay.
Yeah.
Got it. And then here, like, are these holes or is this?
That's the mesangium. I want to pay attention to the mesangium on the silver stain. Yeah.
Okay, got it.
And then notice the other capillary loops though look smooth and intact and not duplicated. Yeah.
Yeah. This is PAS stain. And then these are just a lot of tubules here. You see one glomerulus here. In this glomerulus, it does look like maybe I don't see a crescent in this one.
Yeah, that one's dead.
This is just
sclerosed. Yeah.
Got it.
Yeah.
And then it looks like there's maybe some sloughing here, ATN.
Yeah.
Here and here.
Yeah, loss of brush border, sloughing of epithelium. Yeah, the ATN was diffuse.
Okay. Okay, and then this is H&E stain. And we see our red blood cell casts here again.
Yep.
And then this looks like our crescent with the glomerulus.
Yeah.
Scrunched up.
Yeah.
Okay.
I just wanted to point out the red cell cast in the biopsy. Yeah.
All right. Okay, and this is immunofluorescence, and it's IgA. So we have IgA deposition. It's lighting up, and it looks like it's lighting up in the mesangium.
Yeah, predominantly mesangium and a little bit of capillary wall in some areas, like around 2 o'clock.
2 o'clock.
Yeah, go back there. Yeah, you could see that loop, follow that loop around. You could see the deposits are in that loop. Yeah.
See, okay.
But you're right, predominantly mesangial.
And this is electron microscopy. So I always have to orient myself with the podocytes. So the podocytes are here. So this is the urinary space. This is the blood space. And looking for deposit, it looks like this is a deposit in the mesangium, right?
Right. Yep.
And then looking
on the fluorescence.
Okay, and then looking in the capillary wall, I don't really see deposits. Maybe is this something?
Yeah, that might be a vague perimesangial deposit there. Yeah.
Okay. In terms of podocytes, it looks like they are I would say effaced here a little bit.
Mm-hmm.
Yeah.
Yeah, kind of diffuse. Yeah, diffuse in this picture. There's another loop way over at 9 o'clock that looks completely flattened way over on the side of the screen.
Oh yeah, right here.
Yeah, and keep going to the left. Yeah, that's
yeah.
another loop over there. Yeah.
Okay.
Yeah. The GBMs are a little thick there, David. Just wondering.
They measured within normal limits overall.
Thank you.
Okay. And then another electron microscopy slide. So the podocytes are here again, diffusely effaced here. This is the urinary space, this is the blood space. And then these are mesangial deposits again.
Right.
Okay. All right, so looks like we have IgA nephropathy, mesangial deposits, we have ATN, and then there were red blood cell casts too.
And then just straightforward IgA nephropathy or presenting.
Oh, presentic
Yeah.
IgA nephropathy,
There
yeah.
you go.
David, what percent were crescents?
There was a good sample, 37 glomeruli, 12 out of 37 had necrosis or crescents. So about a third.
Yeah, yeah. 'Cause obviously, you showed the
So it's a C2 lesion.
predominance of crescents. Yeah.
Now, why didn't you call this IgA vasculitis as opposed to IgA nephropathy? Now, the patient does have a rash. It's never been biopsied. It's not palpable. It's said to be macular. And as you know, the lesion in Enoch-Schoen line can be initially petechial. It can be macular. It can be sometimes rarely urticarial, but most of the time it's palpable. Leukocytoclastic vasculitis. I would not be at all surprised if you biopsied this patient's rash that it would show IgA deposits, and in that case, the patient would be classified as an IgA vasculitis, not IgA nephropathy.
The rash was unilateral. It was kind of felt, it was really clinically felt to be a cellulitis and was responsible for the fever. But I would ask you this, I mean, if David doesn't know anything else besides the biopsy and all he sees is crescentic IgA, it's not really his to call IgA vasculitis. Isn't that a clinical diagnosis associated with something beyond? Okay.
Absolutely. Roger, your point is well taken, and I'm not asking the pathologist to
I see. Okay.
call it IgA vasculitis.
Gotcha.
That's the clinician's perspective.
Yeah. Okay. By the way, Michael, that was a great read. By the
was
way,
reserved for more than 50% involvement. Is that not the case?
What's that?
I thought the term crescentic IgA was reserved for those patients that had more than 50% of glomeruli involved with crescents.
That's debated, Stephen. I think the literature ranges anywhere from greater than 30% to greater than 50%. It's clearly the C2 lesion. A C1 lesion would not qualify a patient for being called crescentic GN. It'd be IgA nephropathy with superimposed crescents.
Right. No, I'm not talking about, I'm just talking about in general.
Rapidly progressive glomerulonephritis, presumably, red cell casts in many tubules, crescents involving 33% of the nephron population. This is crescentic glomerulonephritis.
I only bring it up because when we reported our patients with IgA nephropathy that had
over 50%, I think, is held by a minority, I would say. Over 30%, certainly a C2 lesion.
I'm not disagreeing with you at all. What I'm trying to say is that when we tried to get our manuscript published about IgA with crescents, we used the term crescentic and completely got blown out of the water because of the whole issue. Whoever had reviewed it made the point it had to be 50% or more before you used the term crescentic IgA. And I agree with your comment.
Mario,
I wasn't the reviewer on your paper, Stephen, but I wouldn't have brought up that.
Mario, are you still on?
Yeah, I'm here. I'm here.
You want to just tell me what you last week or two you followed up and you spoke to somebody recently about where this whole 50% came up with?
Yeah, so I spoke to Charles Jeanette because the 50% keeps coming back. I'm coming back. And I said, okay, is there a data on where this 50% came from? Is there a reference? And his answer was, that's totally arbitrary. Somebody came up with this and is no longer accepted as a criteria. So that lends support to what Dick has said.
Great. I think for sake of time, we're going to move on to our poll number 2. So poll number 2 says, how would you treat this patient? Would you treat this patient with steroids alone, steroids with rituximab, steroids with cyclophosphamide, or basically just a supportive non-immunologic approach? I guess we have a 5 other too.
Pretty quick answers here. We'll give it a few more seconds. All right. It's pretty.
Yeah, I think it's good enough. Yeah, so the number one is steroids plus cyclophosphamide. Second is steroids plus rituximab, steroids alone. And basically 2 people thought, maybe we should just throw in the towel and give supportive non-immunologic approach. Quickly, Bill, what would you do?
Yeah, I think that knowing that the baseline creatinine is so good, I think that the most aggressive immunosuppressive regimen that we can kind of come up with is probably warranted here. Now, obviously, she's had so many other things with her tyrosine kinase inhibitor and her checkpoint inhibitor. You want to make sure that anything that we give is not going to pair her oncologic treatment, because that might ultimately be more important than her nephrologic treatment. But I was thinking number 3, steroids plus cyclophosphamide, and possibly even considering rituximab and cyclophosphamide. I'm not saying that's been studied, but I think that a really aggressive approach here is warranted, knowing there's AKI, there's crescents there, it's all acute. If we can control it, I think that might be the best thing for her.
What about the argument that she's, kind of old, kind of sick?
Yeah, I think that comes with seeing the patient, and you did see her. So I think you'll always have that in your back pocket, and nothing beats seeing somebody. But you did say that she actually looked pretty good, with the exception of a little cellulitis when she came in. She didn't really appear so sick. From my take home for you is that her functional status is not that bad. And usually if their functional status is good enough to get all this other oncologic therapy, then hopefully she'd be good enough to get this too. But I would defer to the person seeing the patient.
Dr. Wagesbeck, what would you treat her with?
So I think also the seeing the patient is important. She has stage 4 cancer, and it's metastatic to the point where she had an endobronchial lesion that she was admitted for. And now we're also treating her for potential cellulitis and infection. Yes, being on dialysis and her worsening kidney failure is obviously of concern, but I think first and foremost, having an open and honest discussion with the patient about what she wants. And I do think though that the cyclophosphamide option, if she is functional status is well enough and we don't think there's true infection and it doesn't hinder her other therapy, I mean, anecdotally, particularly in older patients, seen pretty good tolerance of the cyclophosphamide and resolution of this crescentic GN in this type of case, and well tolerant. So I would probably have that as my first choice of route after a good discussion of what our overall goals are for her.
Yeah, thank you, David. People have asked a couple times about the C3 on immunofluorescence. Do you have that in front of you?
The IgA was the strongest at 3+. The C3, I would say, was like 1 to 2+.
Okay. There's just a couple comments. One was, that Dr. Reen would do a frailty score. I think that's a really good point. There's a question of an IgA dominant infection-related GN. That's always a possibility, although it didn't really have that, what you might see is a suppurative kind of GN with polys, but not always. Yes, Dick?
Well, I was going to raise the issue again of IgA vasculitis. I know that the clinicians attributed this rash to cellulitis, and I know it's unilateral, but if this patient has IgA vasculitis, steroids and rituximab are probably the treatment of choice. Rituximab is ineffective in IgA nephropathy. Now, it hasn't been studied very well in the crescentic forms, I will admit that. And in IgA vasculitis, cyclophosphamide has been shown to be ineffective in a randomized controlled trial. So I think the issue of, is this secondary IgA nephropathy, perhaps to drugs, or is it IgA vasculitis is a particularly naughty one, and I might just use steroids alone because of the uncertainty.
Interesting. You know, it's, well, let's go to the next slide. So I felt pretty strongly looking at this as like such a bad crescentic GN that there's, you know, the literature for rituximab is growing. I don't know how well it is for this. I certainly normally would like to give it, but the thought was here, this is going up very quickly. It's very crescentic, and we have this kind of thought that we talk about here. When in question we give Cytoxan, we call it no regret Cytoxan. We don't want to, because we still believe it's a stronger drug for a necrotizing process. Now, I think that's yet to be proven, but no regret Cytoxan was our thought. We started her on prednisone, we gave her cyclophosphamide, her creatinine came down very nicely. So we were all congratulating ourselves on our choice, and she seemed to be tolerating it pretty well. Next slide. But then shortly thereafter, her creatinine started climbing, and continued up to the point where we had to start dialysis. And this was quite shocking because really nothing else was going on. She was fine, or all our other parameters looked fine. Nothing new had happened, no new drugs or anything else, and now she's on dialysis. So next poll, don't usually have 3 polls, but what would you do now? Would you rebiopsy her? Would you add rituximab, or would you just supportive therapy and, you know, say we gave it the college try? And we've had enough. We're asking for trouble with more therapy.
Interesting.
We get to see the poll as it comes through for us.
Not what I would have expected, but it's interesting.
Dr. Rubin says, what is going to kill this lady in the short term is infection. I will comment on that in a second.
All right.
Okay, you can show the results. But basically, the winner is supportive care. I think a third of them said add rituximab, and a fourth said rebiopsy. I really didn't want to put this lady through another biopsy, and I actually agreed with Mario. I think that, you know, enough's enough. That was the whole point of cyclophosphamide. I think we were just asking for trouble. But, you know, there's no way to know for sure on that. So this is what happened after the cyclophosphamide. This is her white count was 4.2 thousand. Her hematocrit was a little lower. Platelets were 79,000. Doesn't make the first biopsy so exciting to begin with. 1 month later, her white count was 1.9, and hematocrit and platelets are now at 29,000. And we were really, you know, thought, holy cow. But maybe we give a little more time, it'll get better. And by 2 months later, her white count's now 1.5. I'm screaming to heme to give her GCSF, and they say, yo, you just have to hang in there. Platelets are now 20,000. So instead, you know, instead of us being no regret Cytoxan, I had major regret Cytoxan. I thought I really did the wrong thing and probably should have given her something, you know, along the lines of in the first place, that I may end up being this woman's demise from my overly aggressive therapy. You know, she might have looked okay, but she really was, you know, not a young woman with cancer and having a lot of chemotherapy. Well, eventually this led to a bone marrow biopsy, and sure enough, she had MDS, and she probably had that all along, and this is probably related to her mild, you know, cytopenias here before this all occurred. So fortunately, I don't think that I contributed to this, but certainly goes against giving any more chemotherapy or whatever agents for her glomerulonephritis. And now they're treating her with azacitidine, which is a drug for MDS and myelomonocytic leukemia. It hasn't really done much yet, but she remains on dialysis. The real question is, what happened here? Why did she do well and go up? And I don't have an answer. We didn't rebiopsy her. I really felt strongly that we gave it the college try. No regrets, maybe over regrets. But I was pretty much going to say, okay, we have a live patient who otherwise looks good on dialysis, and I'm not going to push my luck. But what is this? What was this from? And so one of the thoughts was that maybe it was has to do with all of this here, all these red blood cell casts, because there is a literature on severe hematuria and red blood cell casts leading to AKI. And I'm going to go over this just very quickly, not a lot of details, but if you look, a quick review, there's no shortage of articles of talking about this in IgA nephropathy, that independent of the glomerular lesion, that there's a subset of patients who develop acute renal failure. Many of them have had macroscopic hematuria. They have, in fact, the majority of them will have macroscopic hematuria or even, gross hematuria. We went back and asked her at one point, and we weren't trying to deceive anybody in the protocol, but she said, yeah, my urine had been blood tinged. This preceded the renal biopsy, but it wasn't clearly gross hematuria. But she had some blood tinged urine all along, and that kind of also points to the whole IgA kind of phenomena. But I think that there's a possibility that that's kind of the pathophysiology or whatever else might be going on. That in the end, this was not so much a end-stage renal disease from GN, but an end-stage renal disease maybe related to this process. What all these papers had in common is that they had a lot of crescents, they had a lot of red blood cell casts, and they often had gross hematuria. And it also reminds us of warfarin nephropathy. And this is my a screenshot of all the articles I have on that disease, which is a very similar disease in many respects. Gross hematuria with AKI, and you biopsy, and the only finding is a lot of red cell casts. And these patients don't always have a good prognosis, and they don't always have a good prognosis in IgA nephropathy. This is not something you could just think that will go away as like the GN that might be treated. So I don't know if that's what's going on or not. I'm just proposing it as a possibility as to why she got worse. The pathophysiology. Oh, by the way, what's very interesting is that in patients with anticoagulated related nephropathy, many of these patients have found to have an underlying IgA nephropathy. So it may not even just be the anticoagulant. It may be a combination of warfarin and an underlying IgA nephropathy in many of these. Regardless, this is kind of a schematic of what some of the thoughts are related to this. You have a lot of erythrocytes in the urine. They break down. Free iron is released. It's a free radical. You have oxidative stress. It gets in the cell. It leads to apoptosis and cell death. And we all know how potentially all the mechanisms we heard about how iron can be bad. And I don't know, again, if that's what's going on, but we do know that there is this phenomena of gross hematuria and significant red blood cell casts and AKI. So I don't know, because I really don't have another explanation. That's kind of what I think is a possibility that's going on here. It's now been a couple months and she has not gotten any better. Fortunately, she's getting her chemotherapy, her drug for her MDS, and is doing okay. They've decided not to treat her cancer anymore, at least I have an alive patient, which I wasn't so sure at one point from the aggressive therapy. Mario, you have something to say?
Yeah, and I wonder if Dick will comment on this because he recently noted the association between myelodysplastic syndrome and TMA, whether these patients' low platelet was a reflection perhaps of TMA. Why all of a sudden, I don't know, but certainly is a consideration. And lastly, as I put it in the chat, I think we need to remember the contributions of Bill Bennett and Kincaid Smith in the entity you just described.
Yes, good point. Dr. Reen?
I think I'll come back to the frailty score. We do quite regularly antibodies over 70 before offering immunosuppression, and it has worked well for us. Some patients have decided not to take the chemotherapy, immunosuppression. Some have decided, but at least they know they are at higher risk for the infections or other side effects for this. So I think it's a valuable tool which one should do. And if my guess is that if you would have used in her case, you may have second thought of using cyclophosphamide. And there is a paper about that.
I don't know if you could do it fast enough, but if you could throw the reference in the chat, that would be wonderful.
Yeah, I'm trying to find it, but it's in my office, so I will actually email you later on.
Okay, that's great.
Mario, thanks, Mario, for bringing up this issue of the myelodysplastic syndromes and their relationships to TMA. This came about because of a case posted on the open forum. The literature pretty clearly shows that there is a strong association between renal limited TMA and the myelodysplastic syndromes, even in patients treated in a fashion not including tyrosine kinase inhibitors, such as hydroxyurea. Exactly why this relationship is found is not clearly understood, and nobody knows how to treat it. There are other glomerular lesions that can be seen in myelodysplastic syndrome, including membranoproliferative GN pattern of injury, FSGS, and rarely, interestingly, IgA nephropathy. So it's a fairly heterogeneous collection of underlying diseases. This patient, when we look at all of the pathology, had no evidence at all of renal limited TMA. EM showed no endotheliosis at all. The light microscopy was not compatible with TMA. This was purely a severe crescentic glomerulonephritis, ANCA negative, which actually is not really commonly described in patients with myelodysplastic syndromes. I can't speculate as to what the etiology of an ANCA negative crescentic GN due to IgA was in this case. I suspect the drugs had something to do with it, but I can't be sure.
Well, I think it's an interesting point. You know, what did anything trigger this? Is it bad luck? Is it a GN that's showing up from an immune checkpoint inhibitor 14 months later or not?
Yeah.
My fellow, you know, about an hour before the case, texted me and said, "What about the fact that this patient had RSV? You know, she had an upper respiratory tract infection, and maybe that's what triggered it." And I'm like, "Well, good for you, Bhavna, because that was not on my radar for a long time. I clearly biopsied this patient thinking she had a TMA from her chemo. I really thought that the checkpoint was too far out. I did not expect IgA nephropathy at all, but of course that's why we do renal biopsies. You know, if I changed the story and I said an Hispanic woman had AKI and had blood tinged urine and didn't have all the other stuff in there, I think we would have had a pretty after a respiratory tract infection, I think, you know, everybody would have picked IgA nephropathy, but it really didn't present that way to us. And, you know, you think everything's clear in retrospect. It's a shame she didn't do better. Her renal lesion, I mean, she had a third of her glomeruli had crescents, but a lot of those glomeruli look pretty good. And I would not have expected that to lead to end-stage renal disease. So I don't know what else happened. I proposed the idea of the hemoglobin uric renal damage, but that's, you know, that could be total folly. But it just gave me an opportunity to talk a little bit about that mechanism, and I'd be open to anybody else's ideas. But
Yeah.
fortunately,
Roger, many years ago, Priscilla Kincaid Smith and I did a roundtable discussion of AKI and IgA nephropathy, and Priscilla said, you know, all of the patients who had AKI due to gross hematuria recovered from it after a period of sometimes oliguria and sometimes dialysis requiring, except the patients who had over 30% crescents in the original biopsy. So the fact that this patient did not fully recover and actually went on to end-stage renal disease is probably more attributable to the crescentic part of her disease than to the red cell casts in the biopsy, and we don't know whether she had red cell casts in the urine.
No, but I don't think the red cell casts in the urine are doing it. It has to be what's actually in the kidney. But you know and I have no problem with that. It was a terrible lesion, but it got better for a good week and a half. Her creatinine came down very nicely, and then it took off again. So, yeah. I mean, we could have rebiopsied her, but I just thought, you know what, I'm asking for trouble. I've already, you know, she's got her platelet count was low, and enough's enough. Yeah. And I am glad that she, you know, didn't lead to a worse outcome. But nevertheless, great points by everybody the same. I want to thank Dia for joining us, and for Dr. Juan Carlos Velez. We always enjoy having our outside guests and their comments. We really appreciate that. And thank you, Mario, for your comments aloud and in the chat, as well as Dr. Reen. We'll be off for 2 weeks. Most of us are going to be out of town, but we will be back in 2 weeks. And thank you, everybody, for coming. Happy
Thanks,
Ramadan,
Roger.
and we'll talk to you soon. Everybody stay
Great
safe.
case. Thank you.
Thank you, everybody.